So let's talk about Medicaid. So the Medicaid population, as you know, is one of the most medically needy low-income population. It's the population where not only is there health illiteracy, but there are true access issues. I remember going out with Jeff Brenner to the Camden Project some time ago, and I sat with the Community Health Council in Camden. And for those of you who are not familiar with it, you know, one of the things that Jeff Brenner's been doing is leading the Hotspotter initiative, which is let's look at where patients are utilizing the most resources, and let's deal with those patients, the sickest, the highest risk, the high utilizers, and let's fix the system for those patients. There's enough data that talks about 5% of the population resulting in 50% of all healthcare dollars spent here in the country. So if we were able to just identify those 5% of the population, deal with those patients, help them, provide them with the support and everything that they needed, it would be great. So I go out to this community health group or advisory council, and sort of talk to the high utilizers of healthcare resources and said, what is it that, what are some of the barriers that you're facing? And I said, well, you have an FQHC right close to you. You have Medicaid. It's not like you don't have insurance. It's not you're not uninsured. You do have Medicaid. And the answer I got back was, was very basic. And here we're talking about, okay, how do we reform the system? How do we get the 3 hospitals to work together? And they said, all we need is a 24-hour access to a nurse practitioner. Because if we go and do 2 jobs, and we have a sick child, and we need to go into an urgent care or to an FQHC, it takes a month to get that urgent visit, right? It takes 3 months to get a primary care visit, even with insurance, because we have Medicaid. So the reason I'm telling you the story is that we can come up with all the solutions possible, but unless we talk to the folks who are utilizing and are in that situation, we're not truly going to come up with what's important to them and customize, the impact of what needs to be done. So Medicaid is going to be key. Engaging that population is going to be key. The premise of the Affordable Care Act was and is that we will be providing universal health care insurance, because that's the only way a healthcare model works. You can't have the high-risk patients utilizing resources without having the low-risk people also contributing to the healthcare system's finances. So that's the only way it's going to work. So the goal of the Affordable Care Act was really to provide universal coverage, and the way that happens is as a result of the individual mandates, the employer mandates, and the Medicaid expansion. And all of this comes through the Health Insurance Exchange, which is a single portal of entry based on which there is a streamlined, integrated process of both eligibility and enrollment that has to happen. So a lot of things have to happen to make this work. But that's sort of the premise of the Affordable Care Act in making sure that there is universal coverage. And the universal coverage, again, based on Medicaid coverage in 2013, we provide for the low-income population. The low-income population when it comes to pregnant women, when it comes to children, when it comes to the aged, blind, and disabled, right? But there's a huge chunk of the population, which is the adult, uninsured or low-income population that does not get covered with Medicaid. So what we're going to see as a result of Medicaid expansion is the fact that that entire population will not get covered. Today we get a 50-50 match, so it's a partnership program between the state and the feds. As a result of the Affordable Care Act, for the first 3 years, 100% of funding is provided by the federal government. The next 3 years, you see a scaling down of the contribution by the feds, the 95, 94, 93%, and then from 2020 onwards, we see a 90% contribution by the feds. So again, today we get a 50-50 match. This obviously is much better because this is a fully funded federal program for the first 3 years, and then a small amount of contribution that we have as a state have to make. This is sort of the rationale between the Medicaid expansion. As a result of Medicaid expansion, it is thought, based on assessments, that we're going to have 16 million new Americans being insured through Medicaid. And the reduction in the uninsured will will be 11 million. And so we go from 85% fully insured or covered population in the U.S. today to 92%. So even if all the states went for expansion, we would never get to 100% fully covered or fully insured population. And so Medicaid does play an extremely important role. So with the Supreme Court's ruling initially, the law stated that unless you went for Medicaid expansion, you were at risk for losing all of your previous Medicaid funds. As a result of the new Supreme Court ruling last year, it is a voluntary program. So a lot of the discussion that you hear across the country is about whether states are going to go for Medicaid or not. And there are lots of pros and cons to going each way, but for every state, the decision has to be the best decision for its own state. It does provide insurance for about 60 million Americans. It provides insurance and assistance for 9 million aged and blind population. That is the low-income Medicare population. 1 million nursing home residents. It is a huge safety net system for our hospitals and healthcare infrastructure through various kinds of funding. And it is the #1 budget item when it comes to federal funds coming into the state. So 44% of all federal dollars that come to the state comes through Medicaid. So again, this is a huge piece of not only our state budget, but also our safety net and really being able to provide care for the most vulnerable and the most medically needy population. So it provides coverage for 42% of the poor, it provides coverage for 30% of all children, over 50% of the low-income children, 70% of nursing home residents. That's huge, and that's sort of the premise of what we were talking about, of rebalancing and seeing how we can shift some of those dollars. 44% of HIV and AIDS patients, and 17% of the Medicare beneficiaries. Those are the low-income Medicare beneficiaries. When it comes to where these dollars get spent, they represent 17% of total healthcare dollars spent in our country, 19% of hospital care, 32% of nursing home care. This is just to give you the magnitude of the kind of the role Medicaid plays in taking care of the population. And when you look at this data, it's not different from any state. This is national data, but even in the state, our data is very similar, where we have about 75% of the population, which is the young population, representing only about 30% of the healthcare dollars spent out of the Medicaid budget. But 25% of the population, which is the aged and disabled population, representing 70% of healthcare dollars spent. So versus concentrating on the adults and children, the focus has really been on concentrating and looking at reforming care for the aged and disabled population because of the cost that gets driven as a result of it. And this just tells you that as you're becoming older and as you have disabilities, there is more health care that's being spent not only in acute hospitalizations but also on long-term care. For the younger population, a lot of the care is around outpatient care. And this is just to tell you about the 9 million dual eligibles that we have. And again, this is nothing different. So 15% of the dual population, which is the Medicare and the Medicaid, the low-income Medicare population, represents 40% of all of healthcare spending. So 15% of the population actually represents, 15% of the population represents 40% of the Medicaid budget. And of that, we have 70% of that budget going to long-term care. So those are going to be some of the key factors as a foundation when you look at how and why we need to reform healthcare. There are other provisions in the Affordable Care Act, the Center for Medicare and Medicaid Innovations, that has allocated $1 billion every year for the next 10 years to look at reform ideas. This is actually insulated from the sequestration discussions and the budget discussions in DC right now. There are lots of provisions for doing demonstration projects. Another key provision is the enhanced funding for physicians. So we in the state of New Jersey have amongst the lowest Medicaid reimbursement for services provided by physicians and hospitals. For the next 2 years, 2013 and 14, we're going to be, the reimbursement will go up and will be at par to Medicare reimbursement. Now, what's going to happen after those 2 years is going to be another opportunity, and there's a lot of payment reform that's happening so that in 2 years, hopefully the income that the providers are getting will somehow stay whole. So those are some of the initiatives that we're going to be working on. And the DISH funding will obviously be going down. We think we get about $1 billion in DISH funding in the state. It is anticipated that that funding will go down by about 50%. So what is the rationale for some of the decisions that we've made here in the state in terms of the Medicaid expansion? We all know here that we did move forward with Medicaid expansion, and I think it was the right thing for our state here. The reason why it was important for us is to really go back a little bit in terms of what we did in terms of the comprehensive Medicaid waiver. So what the administration did in the comprehensive Medicaid waiver is that we want to bring and make our Medicaid program more efficient. And as a result of that, they submitted a waiver application to CMS. And with that, there were key provisions in that Medicaid waiver application process. One of it was the behavioral health provision. We all know that when patients have both medical illnesses and mental health illnesses, the condition becomes more complicated. Having worked in a health plan before, I know that the leading cause of patients going into the emergency room repeatedly, or the high emergency room utilizes, was as a result of comorbid medical and mental health issues. If we can somehow streamline it and bring it together, it's going to help with improving care, improving quality, improving outcomes, but also improving the efficiency and cost to the system. So this was one of the big provisions of our comprehensive Medicaid waiver application that got approved, where now we would have a single behavioral health agency administering the behavioral health benefits to the Medicaid population and collaborating with managed care so as to co-manage the medical as well as the behavioral health problems that patients have. This is going to be very important. I don't know how many of you have had a chance to look at a recent study that was published by Harvard, the Harvard Policy Group, along with Oregon State, where they looked at a population that was randomly assigned to Medicaid, and they had a control population as a result of a lottery system that could not get enrolled into Medicaid. And when they looked at initial outcome measures, there were two aspects of those outcomes that were very powerful. One aspect was there was more financial security for people who were on Medicaid, and the second piece was behavioral health and mental health improved in patients who were on Medicaid. The study was not powered to the level where you could actually look at objective changes in physical health in that study. And so there was no assessment made in terms of improvement in physical and medical illnesses in patients who have Medicaid. If anything, the cost actually went up in the short term because they were utilizing more resources. So again, behavioral health is a very important piece in that population. And in fact, as we get as we expand our Medicaid, it's going to be critical to start profiling our patients around risk stratifications so that we can identify those patients who are sickest and who have mental illnesses and be able to coordinate the care for them. That's going to be a huge initiative for us. We talked about long-term care services and rebalancing them and having a care coordination structure so as to identify what the best resources are for these patients so that we can transition them to the home setting from institutions or prevent them from coming into institutions. And that's part of our managed care strategy. Again, streamlining the whole eligibility process, coming up with new incentives where healthcare delivery systems like hospitals now look at quality outcomes. And you connect that to reimbursement is going to be key, and that's one of the grant funding opportunities that we have through the federal government. And then looking at various programs that were just state-only and transitioning them to state and federal programs is a huge opportunity for us. So those are some of the key elements of our comprehensive waiver. So why did we as a state go for Medicaid expansion? The one most important thing that when we look at the Medicaid system is that we're expanding upon a reforming system, right? So we've already taken those steps in terms of behavioral health and long-term care. That's why I emphasize so much on those two elements in my previous slides. Those are the two key elements that drive cost in this most vulnerable, medically needy population. So if we can somehow start reforming those systems as a basic foundation, then we can build upon something that's stronger. So that's going to be an important piece. So that was sort of one of the big premises behind why the administration actually went in for Medicaid expansion. In addition, we were able to transition some of the old eligible, the categories where we had a 50-50 match to a fully federally funded program. So as a result of that, despite increasing our numbers, we saw in terms of our bottom line, $224 million added to our budget as a result of this program for this budget cycle. Another big concern was that we have a state-only program, which is the General Assistance Program for people up to a federal poverty level of 24%. Now, the Medicaid program, in terms of expansion, or actually the health insurance exchanges, with their subsidies, don't start until 100% federal poverty level. So you would have had that gap for the population between 24% and 100% of federal poverty level if we didn't go for Medicaid expansion. There was no other program that would take care of that patient, that population, because the subsidies in the exchanges don't start until 100% of NPM. So again, those were some of the reasons, and at the end, I feel that this is a voluntary program, so if it doesn't work, we can always decide not to move forward with it in any year.